Everyone, welcome to researchmd.com. Another great presentation. We're going to teach you electrolyte abnormality today. The topic is hypomagnesemia. All our presentation, remember, under 9 minutes, everything compressed, okay? Make sure you repeatedly watch the presentation. So that's why we're just going to stay in our memory. There's no point in watching an hour-long video if you don't have time to review it. The key is review it again and again, so long-term memory kind of kicks in. Again, my name is Pramil. Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students, residents. I'm also director of research. I'm an assistant professor of medicine, 2 major medical schools. So let's get into our topic. So when you talk about magnesium, reference range, that's the first thing we need to know. It's 1.5 to 2.0, okay? Magnesium balance is closely linked to 2 other electrolytes you need to know. It's calcium and potassium homeostasis. Though it's very important to know that. We'll come back to that. Magnesium prevents intracellular accumulation of calcium. A balance of intracellular magnesium and extracellular calcium is required to maintain normal neuromuscular activity. So if you have to remember 2 electrolytes very closely linked to think about calcium and potassium, okay? Magnesium is one of the main intracellular cations. Remember, it's a cation. It's a cofactor, large number of enzymes and transporters. That's why the effect is like huge when you have hypomagnesemia. Regulation of magnesium homeostasis, reabsorption rate in the kidney, all of this kind of the body create the balance, right? The other hormones, PTH, play an important role. Insulin, glucagon, PTH, calcitonin, ADH, and corticosteroid, all of that will come back again. But remember, in a brief introduction, magnesium is related to many other electrolytes and some other hormones we talked about it, okay? So what is hypomagnesemia? Serum magnesium concentrate less than 1.5. What is critical or severe? Less than 1.0 milliequivalent equivalent. So in that case, you need to admit the patient, get some IV magnesium, my friends. Okay, so you look at the risk of hypomagnesemia. Again, we talked about hypocalcemia, right? It was really high in the hospitalized patient. Same thing, ICU patient and the hospitalized patient is extremely high. If you are diabetic, high, and alcohol patients also very high hypomagnesemia. That's very, please always remember, alcoholic patient, that is going to have like a hypomagnesemia. So hypomagnesemia, very common. Critically, we talk about all this, and hypomagnesemia commonly is along the other electrolyte abnormalities. We talked about it already. We have to worry about calcium. And let's get into our etiology. In gastrointestinal, there is usually like inadequate intake, like anorexia nervosa. Prolonged fasting can affect. Malnutrition, malabsorption, gastric bypass surgery. So be very careful to make sure when you have a lot of people having gastric bypass surgery, to make sure check the electrolyte. Short bowel syndrome, vomiting, nasogastric secretion. Anytime you have like upper and lower gastrointestinal tract, acute chronic diarrhea, chronic inflammatory bowel disease, acute pancreatitis. Will come back to the recent intestinal fistula, total TPN, and refeeding syndrome. All of this could be the causes. Now, renal causes, diuresis, if we gave diuretics, and if we had acute tubular necrosis, and if we talk about congenital disorder, think about Bartter syndrome, Gittleman syndrome, and familial hypomagnesemia. Endocrine causes, the most common is IRDH, hyperaldosteronism, hyperparathyroidism, and hyperthyroidism, okay? So medications, we talk about the diuretic, think about loop diuretic, thiazide diuretic. Insulin also play a role, and proton pump inhibitor use is very common. That can also be one of the other causes. Aminoglycosides, antibiotic, example, gentamicin, even digitalis, and EGFR inhibitors like sifimiximab and panitumab, all those, and cisplatin also can cause. And other, we talk about alcohol use, like 80% of them can have hypomagnesemia, diabetes, diabetic ketoacidosis, hypercalcemia, critical illness, surgery, trauma, all of this could cause it. Okay, now let's look at the pathophysiology of magnesium homeostasis and all that. Magnesium absorbed. Where does it get absorbed? Small intestine, okay? Magnesium losses. You can both upper and lower gastrointestinal tract. That's why we told earlier there's like diarrhea, and then you're vomiting, and all of that can cause, but magnesium can go down. And hypomagnesemia is very common. It's also in acute pancreatitis. What happened is like this calcium and the fat kind of combine together. That's going to contribute to hypomagnesemia. So it's also very important. In the gut, calcium and magnesium intake influences each other absorption. Okay, a high calcium intake decrease magnesium. A low magnesium intake increase calcium absorption. Remember that. Also, PTH appears to increase the magnesium absorption. Glucocorticosteroid decrease the absorption of calcium, appear to increase the transport of magnesium. So remember that all of this kind of interlink together. So how does magnesium get excreted? Majority of the magnesium go through the reabsorbed thick ascending limb and of the loop of Henle, around 60 to 70%, and the PCT account for proximal convoluted tubule account for like 15 to 25%. A major, a thing we need to know about claudins and the involvement of that. They are the major component of light junction strands in the TAL where the reabsorption of the magnesium occurs. Okay, why is it important? Because you can have mutation in claudin 16, then you can have familial hypomagnesemia, hypercalcemia, and nephrocalcinosis. Any of the familiar you have to know about. So remember the word claudin. Okay. So when you look about the other thing, always we see when we have hypomagnesemia, we have to look at the potassium. So let's look into what is the mechanism of why do you have to correct hypomagnesemia when you have hypokalemia. Okay, the mechanism of hypomagnesemia induced hypokalemia relate to the intrinsic biophysical properties of renal outermedullary ROMK channels, mediating the capillary secretion in the TAL and the distal nephron. Okay, then you have cytoplasmic blocking of the outward potassium movement through the inward rectifier conductance system of the pathway, cytoplasmic magnesium and polyamines. Okay, and then also you can have reduction in the intracellular magnesium results in the loss of inward rectification, thus causing greater outward conductance of K plus ions through the channels. The bottom line, you're going to lose K through urine. Okay, so that is the main mechanism right here. Now let's look at hypocalcemia. Again, we talk about closely associated with hypocalcemia, right? Impaired PTH secretion and refractory to the bones and tubules of PTH. And then let's look at neuromuscular manifestations are usually present with the weakness and neuromuscular irritability, including tremor, fasciculation, tetany, because of the calcium relation. Also, some of this magnesium is the required stabilizer of the axon. Okay, extracellularly, magnesium iron can block neurosynaptic transmission and release of acetylcholine, and a lot of others you can do. Nephrolithiasis is the other, is an inhibitor of urinary crystal formation. Diabetes, magnesium deficiency decrease the insulin sensitivity. Okay, and hypertension appears characterized by decrease in the intracellular free magnesium lead to increased vascular tone and reactivity. So hypertension, hypolipidemia. What happened to hypolipidemia? Serum magnesium level is inversely related to the serum cholesterol concentration, and then you have a lot of medications kind of associated. Clinical features. We talk about all this kind of clearly mentioned here. The gastrointestinal, like anorexia, nausea, vomiting, neuromuscular muscle weakness, lethargy, tremor. You got cardiac, you can have arrhythmia. So be very careful about that. Diagnosed hypomagnesemia, we talk about less than 1.5. And then how do you treat it? Magnesium supplementation, repletion is all considered. It should be, we talk about is, let's go through the list. Patient with severe symptoms, we talk about tetany, arrhythmia and all that. You need to admit the patient to the hospital, start giving IV. Hemodynamically unstable patient, you can have 1 to 2 milligrams of magnesium sulfate. In hemodynamically stable patient, you can, all of those kind of given right here. And patient with no or minimal symptoms, you can give oral supplement. Okay, for routine IV repletion of maintenance of the doses or gear, if it is severe, used to give 4 to 8 grams of magnesium sulfate into 12 to 24, and if it is moderate, 2 to 4 grams, and mild, it is up to 1 to 2 grams. So if we correct, first of all, always correct the underlying causes, and duration of therapy, it may take 2 or 3 days to stabilize the magnesium. These are the reference. Thank you so much for watching. We'll be back with another presentation soon. Thank you. How long it took.